The ads you get in your mailbox for free dinners saying you can get someone to come to your house and give you stem cells, that's fake. It's fraud, and it's bad, and people can get hurt. And just because the surgeon doesn't want to operate on you doesn't mean your spine is fine. It's not a surgical problem, but it's a problem. There's a lot of misconception about what interventional pain management is. It's like, we're not drugs. We're not giving you narcotics. We're not, trying to get you hooked on drugs. We're using needles, usually some sort of an injection, to try to target things specifically.
Hi, everyone. I'm Joshua Lyon, a physical therapist and the owner of AIM Advanced in Motion Physical Therapy and host of the Provider Spotlight series. With us today is Dr. John Knab. He is board certified in both anesthesiology and pain medicine. He's an interventional pain management specialist specializing in regenerative medicine and non-surgical spine and joint care. He is the founder here in town of the Center for Pain Management and Regenerative Medicine. He's also the founder of Elite Spine and Joint, which focuses exclusively on the regenerative therapies. Outside of his very busy professional life, he enjoys time with his family, being active in Wilmington here, and rumor has it, a very strong love for pizza making, having owned over 10 different pizza ovens. So I want to dig into that here in a little bit. It's truly rewarding seeing people regain function and get back to activities they love without going down the road of major surgery or long-term medications. I know you're going to learn a ton from him, and I'm thrilled to have you on the show. Thanks for joining me, Dr. Knab.
Thank you for having me. I appreciate it.
As a lover of pizza myself, tell me a little bit about that personal hobby.
Right. Well, I think it goes back to childhood. It's always been like my top 5 favorite foods. And maybe about 2010, I started trying to make pizza on my grill, and then it just blossomed from there. And so I've got basically a professional wood-fired oven in my backyard. But when that's too big to fire up and I'm only cooking for 2 or 3 people, of course, I need different size pizza ovens. So that's why I ended up getting probably a total of 10 throughout the years since then, but 5.
You're scaling back your operations here. Okay.
Scaling back, yeah, trying to downsize. But
I know most people watching this are going to want to know more on the professional side of things. So let's dive in a little bit. I always love hearing your story. What got you into healthcare, specifically pain medicine, and kind of your overall approach to care? So what's your story there?
Rapid fire. My dad was a doc. He was a surgeon. And so I kind of liked going into the hospital with him and kind of seeing how it worked there. I thought all the whole organization of medicine was cool. So that was my earliest exposure to medicine. I ended up doing pre-med, and I was a kind of a Spanish major and pre-med major at Middlebury up in Vermont. Then went to a medical school at the University of Vermont. From there, went out to Seattle to do an anesthesia residency. So during medical school, you kind of cycle through all the different specialties. I thought surgery was going to be my calling, but it turns out that another love of mine, being on the water and doing stuff, would interfere with the surgical demands. So I thought, well, okay, I like the procedure-based stuff. I like kind of chemistry and biology, and I also kind of like the procedures. So anesthesia was a good fit, and so I went out and did an anesthesia residency in Seattle. And as I was getting towards the end of that, I realized, this wasn't quite what I had envisioned for the rest of my life. I thought it was challenging. It was great. A lot of pharmacology, a lot of physiology, but I was missing the patient interaction. Obviously, you meet the patient before surgery, but then for the majority of your interaction with that patient, they're asleep. Pretty limited conversation. So like a lot of my favorite times were in the pre-op clinic. So when I was evaluating patients prior to surgery, I was just getting their histories, finding out why they were going into surgery, and just kind of, that's what really intrigued me. And so I came upon this field of interventional pain management towards the end of my anesthesia residency, and I ended up doing a fellowship in interventional pain management in San Diego at the University of California. And that was kind of, it just, since then, it really kind of found me, and it's been what I've enjoyed doing for the majority of my professional career. And how it morphed into regenerative medicine was kind of just, the maturation of me as a physician, as a person, kind of looking at what we were doing. I unfortunately kind of came up through the system right at the peak of the time where everyone was saying we must treat pain with narcotics, which we obviously all know now is a terrible idea, but that was what was being pushed on us by the educational system at the university level, back in the 1990s. So I kind of realized a lot earlier than most that this was something that I didn't like. And we got away from that earlier than most. And then it got me thinking about other things that we do. The steroids that we use, the burning procedures with radiofrequency that we use, which are fine and they all have a role. But what if there's another way? What if there's a way that we can kind of slow down the disease process with things that come from us, our own cells, our platelets, our stem cells from our bone marrow? What if there were a way that we could use our own bodies to help heal ourselves? So back around 10 years ago now, maybe 11 years ago, I started looking into this regenerative medicine field, and that's kind of how it started. And again, that's just gone on from there. So, the way I approach everyone in my practice now is I kind of look at the problem, try to figure out what's going on. And then for each individual, there are different options, and I don't think steroids are all bad. I don't think radiofrequency is all bad. And I don't think PRP and stem cells are always the answer either. So I like to have as many tools in my toolbox as possible. I've really been kind of trying to sort out the real stuff from the false stuff, and we can get into that a little bit if we have time. But, I'm trying to help patients understand what the problem is and then give them options so that they can pick and choose how they want to treat it, not just live with the pain or surgery. There's a lot in between, so that's kind of where I am at this point in my career. And yeah, that's kind of what I do.
I love that, especially the fact that you're taking the time to present the options to the patient, not just slapping a Band-Aid on and covering up the pain, but actually get into the root cause and then providing them with options of how they can deal with that and, ideally live a fuller life. So that's wonderful. What about people that, who do you typically see coming through your clinic? What's kind of the ideal patient profile, or what specifically do you treat? What's kind of the most common things that you're seeing in your day-to-day?
So we're primarily spine focused. That's what, that was my earliest training, was in spine, just doing all sorts of injections for people with bad disc conditions, arthritis in the spine. But we also treat peripheral joints, shoulders, knees, hips. So the ideal patient for me is someone who is catching things earlier rather than later. My youngest patient probably was maybe 12 or 13. My oldest current patient is 101. And surprisingly, we see some 101-year-olds or, 90-year-old people with decent-looking joints and spines.
That's amazing.
It's amazing. But the healthier the tissue is that we're trying to treat, the more I enjoy the challenge of trying to, keep that tissue in the person's body rather than taking it out and putting in a metallic implant of some sort. So if I have tissue to work with, I don't care what your age is. I don't care whether you're 80. I don't care whether you're 18. If there's tissue that we can work with and you're a candidate for it, I like working with those patients because, I want to not just improve pain. I want to improve function. I want to improve how these patients are approaching life. And that's, obviously where, my interaction with all you guys and physical therapists all over the area come into play. It's like, I can help the pain, but it doesn't help if your muscles are all atrophied and you haven't used your spine in 4 years and you don't know how to engage your glutes. I mean, treating pain is worthless if you can't improve function. So the more I have someone who's motivated to do those things, motivated to not just feel better, but do something with their bodies once they feel better, that's the perfect candidate for me, no matter what the age.
I love that. Having the active participant beyond just, hey, fix the pain, but let me actually get back to doing what I love doing or do new things that I didn't think were possible because pain was limiting me prior. Like, that's got to be super rewarding.
It is.
Yeah. So what's kind of a common conditions or some of the most common conditions that you'll see coming through the clinic?
Okay. So back pain, right? Everyone, is going to experience back pain. Well, most of us can experience back pain at some point in our life. And admittedly, even until I was a couple years out after my fellowship, I didn't really understand the complexity of back pain. You don't really understand how complex the spine is until you get into it and you start seeing patients and treating patients and realize what made patients feel better, function better, what didn't make patients feel and function better. So I see a lot of patients, kind of narrowing it down into disc problems. So the discs are the spacers between the bones, obviously, that, allow us to twist and bend. Most of the time we think about people coming to the doctor when they've got a disc that's kind of blown out, it's herniated and herniated nucleus pulposus, the most common thing that we see. But a lot of times we hear a patient who comes and it's not really that they've got sciatica or they've got just an acute episode. It's these recurring episodes of pain where their back locks up, they get all cockeyed and they can't sit, they can't stand, they can't bend, they can't do anything. And then it takes them weeks to get better. And then they finally get better. And during that time, they can't do anything. And they finally get better. And then it happens again in 6 months or 12 months or whenever it is. And so those patients are a little bit more challenging, but we see them so commonly where it's not just a disc pushing on a nerve, it's a disc that's degenerated. It may even be leaking some of the chemicals that are inside the disc. You know, the center of the disc is like a jelly donut. And once that stuff starts leaking out, it gets into the spine. It might cause irritation of nerves, but just causes that super, super tight feeling in your back, and you really can't do anything. That's a patient that I see very, very commonly, being a spine-centric practice. And we can do a lot of different things for those patients. Figuring out where the pain's coming from is the first and most important thing to do so that you can kind of begin to tailor treatments for those patients.
Yeah. So someone who's dealing with that, obviously you started impacting their, timeout, all those times that they're on the sideline due to the injury, the loss of function, loss of motivation, because there's this constant fear of, well, it's going to happen in 3 more months again. They get in this cycle. Yep. What do you offer them, kind of maybe talk down the regenerative medicine kind of approach? Is that who that would be appropriate for? Or when you're laying out the options for folks, where does that come into play?
Again, coming back to diagnosis, what is it that is causing you to be here? We see things like poor sitting tolerance. That's pretty common when a person has a disc problem. If they have these recurring episodes, probably something that's at the disc level. And so the first thing is, what have you done conservatively? We always are going to make sure that they've at least tried some strengthening exercises, making sure their iliopsoas isn't too tight, making sure their multifidus are not too atrophied. And we look at the MRI, we can see multifidus atrophy on MRI, and we see it all the time. Wow. You look at the MRI and everyone skips over it. And you look at the MRI and you see, stuff up here at L1, L2 looks like filet mignon, not a streak of fat into it. And then you get down to the lower lumbar spine and it looks like Wagyu. It's like riddled with fat. And so that patient is not engaging their paraspinous muscles. So the key has to be, well, you need to engage that stuff. We need to get you moving.
Yeah.
And then you run into the problem was like, I can't, I am in so much pain that I can't do that. And so that's where I say steroids aren't always all bad. I can use a steroid to get most people I can get out of pain for a brief period of time, whether it's weeks to months, so that they can just start moving in. I send them back to you guys. Now you can work with them. And so then once things have you've kind of unlocked that locked and frozen state of the spine, then we can start talking about, okay, how do we try to arrest this inflammatory process? Maybe not fix it per se, but fix it with the best Band-Aid that we know, which are oftentimes the platelets from our own blood. So that patient who came to me miserable, just they're not able to do anything. I see a lot of young people, active runners, they haven't run in 2 years. Tennis player, pickleball, all this stuff, they just haven't been able to do it because it tweaks their back so much. And I get them to understand that this is not in their head. They might have been told like, listen, your spine looks fine. And just because the surgeon doesn't want to operate on you doesn't mean your spine is fine. It's not a surgical problem, but it's a problem. So once I can show a patient that I can make them feel better, I get a foot in the door showing them and showing their brain and nervous system that they actually are fine. They just need to settle down this inflammatory and degenerative process. We can look towards things that are less destructive. So not using any steroids anymore. We're not going to be burning nerves to joints. We can use the platelets to inject them at multiple places in the spine. So a typical PRP procedure for the spine will involve treating all of the facet joints or the facet joints, treating all the muscles, treating the epidural space, treating the SI joint, treating the ligaments that hold our bones together. Doing that while the patient is really, really comfortably sedated in our office. It's all done in the same day. And those patients, surprisingly, don't have a lot of pain afterwards. They might have pain for a couple days. Then they come back about a week later and start using some of our machines like laser, cold laser. So we're going to be using that to improve blood flow and reduce pain. We have shockwave, both focused and radial shockwaves that help to heal muscle tissue and ligament tendon tissue, and another one called EMTT, which is extracorporeal magnetotransduction therapy, which again helps nerves and muscles and ligaments to heal faster. So we use those machines to kind of speed the process of healing along. And my idea of success for that person is then once they're over that kind of acute phase of pain and inflammation after the procedure, maybe a couple weeks, 2-3 weeks into it, then again, we send them back to get physical therapy. We work with some of the chiropractors in town who kind of really help to mobilize things and get that patient, functioning normally again. And the success there is when I forget about that patient. I see him back for a follow-up at about the 2-month mark and make sure they're doing okay. And then some of these patients I just don't see again until I hear about something else that's going on, or maybe 6, 8, 9 years later, I just see them and I see, how you doing? And they've been doing fine, for years. So, and that's such a different feeling for me than seeing someone every, 2, 3, 4, 5, 6 months for steroid injections. It just feels like the right thing to do. I'm giving these patients their lives back, their bodies back. I don't want to see you. I love seeing
truly restoring them back to health.
Right. Go and thrive. So that to me is the essence of medicine. If we can use our own bodies to heal ourselves, that's great. And sure, there may be things coming down the road with, more purified versions of, actual stem cells that are going to come out from clinical trials that have demonstrated safety and efficacy. That's probably down the road, but, still a little bit off in the distance. So along the way, as I'm doing this stuff, I'm also trying to tell patients that, what you hear on the internet, what the ads you get in your mailbox for free dinners saying you can get someone to come to your house and give you stem cells, that's fake. It's fraud and it's bad and people can get hurt. I'm always trying to kind of emphasize that to my patients. It's like, if it sounds too good to be true, it very well may be, especially in the regenerative medicine field. So I'm a little bit old-fashioned and kind of stuck in the mud about things that aren't, definitely things that are illegal, I stay away from. So that's things like exosomes, umbilical cord stem cells. Those are just plain illegal at the federal level for the entire United States. You can go to places like Florida and Texas where you have the right to try law where you can do it, but I'm pretty conservative and I'm going to use things that come from you, go back into you on the same day. And that's what the FDA says is okay. I know people are really into kind of GLP-1 peptides right now, and I'm not against it, but I don't do it.
Fair enough. What about folks who, I see this all the time, where they just delay care because we're all stubborn, I assume, to a certain point, like, it'll get better in time, and then it actually doesn't. And now it's somewhat debilitating. So what would your message be to folks about, and if you're on the fence, or even if it's like a more recent injury, don't wait, get the care you need, get it addressed early, well before it becomes debilitating. What would your summary message be on that?
Moving away from the spine and towards other things, like peripheral joints, we do see a meniscus tear that's small now. We can heal that. We can heal that with PRP. We can heal that with shockwave even. But the more that you let that go, the more of a negative, inflammatory, destructive environment is going on at the source of your injury. And so athletes injure their ACL, right? And those patients if it's not fixed, there's such an inflammatory and kind of biomechanically off problem that becomes worse and leads to early onset arthritis in those patients, that if they had just kind of addressed it right off the bat, they would be neutral. They'd be just like any other patient who had their ACL fixed immediately. So that's an extreme example, but I think it carries forward to just almost any injury. If you haven't had a good evaluation and you don't really know what your diagnosis is, you don't know if you're causing more harm by not treating. And so at the very least, go and get an evaluation. Hands-on evaluation. We do point-of-care ultrasound in our office, so you can come to me and that same day, I can look at your shoulder, which has been bugging you for 3 years, and I can say, well, listen, you've got a good-looking rotator cuff. You don't have any arthritis of your AC joint. You don't have any major arthritis of your glenohumeral joint. I think you've got a subacromial bursitis, and I can tell you that right in the office. I can even put on like a color Doppler and show you this blood vessels that are just kind of pulsating in areas where they're not supposed to be. That's where your pain's coming from, and I can show you that and treat you without x-ray, without MRI. You can do a lot of stuff right in the office and very quickly if you kind of go to the right type of person. And so that's the other part of our practice that I really love. The being able to put hands on, examine, but also then stick the ultrasound probe on whatever it is, your shoulder, your knee. I can show you you've got a 40 cc fluid collection in the top of your knee. That's why it feels stiff. It's not, you're just imagining it. I can show you your tears in your meniscus. I can show you the Baker cyst. It's a lot of fun.
That's amazing. So first visit they go in, they're going to get, and they'll see that visual as well. So you're pointing it out to them.
Yeah.
It makes sense because now it's like, hey, it's not arthritic. It's not torn rotator cuff. Here's these other things that could be contributing. And you can actually show them right then and there without having to do anything invasive. That's incredible.
Yeah. You don't need an MRI. It's amazing how many people are really terrified of MRIs or just hate them, because of bad experiences. I mean, I love my MRIs, don't get me wrong, but ultrasound is sometimes better than MRI for some of the superficial things that we look at. If a lot of thumb arthritis, carpal tunnel, I can do a carpal tunnel exam right in the office. I can tell you whether it's swollen and inflamed. And listen, we've got two, so I can compare right to left, right?
Yeah.
So,
yeah.
Hey, this one looks big and fat, and this one looks normal. And again, that magic button, I've got this colored Doppler. It shows this blood flow there, which you don't have on X-ray, don't have an MRI. It's really something unique to ultrasound, which is really, really cool. And tennis elbow, golfer's elbow. You see this stuff, it's so great to be able to see this stuff in real time. Yeah, we can show people very quickly what's going on. So I would just encourage people to seek out that type of doc. There's not a lot of people doing musculoskeletal diagnostic ultrasound around, but there's a couple people in town, myself included, who do it. So that's easy because it's painless, it's quick, it's rewarding, it's very, very inexpensive, usually covered by insurance. So getting answers about where the pain's coming from is absolutely the first step, and ignoring it is the wrong direction, in my opinion.
Yeah, the fact that you're providing answers, that's all people want. They want to know what is going on, why does this hurt so bad, and then give me a path forward as to, what are my options. So that leads into our next, topic really is people watching this for a dozen different reasons probably, but fear being one of them, of the unknown. What is it going to look like? What should I expect when I go in and schedule an appointment? And just what could you do to either manage that expectation, reassure folks? What can they expect when they come to see you?
There's a lot of misconception about what interventional pain management is. It's like, we're not drugs. We're not giving you narcotics. We're not, trying to get you hooked on drugs. We're using needles and usually some sort of an injection to try to target things specifically. And we're doing it not just by feel, where does it hurt, and inject it. We're doing it very specifically guided by either ultrasound or fluoroscopy. But before we do any of that stuff, we have to get the diagnosis. So the first visit is going to be talking, examining, and maybe an ultrasound. For the most part, first visit, we're not going to be doing anything painful. You don't have to, anything to be worried about. We just want to get to the bottom of what's causing the problem. Depending on what happens during that first visit, I might say, you need X-ray, you need ultrasound, you need an MRI, you need CT scan, you might need something else, maybe some lab testing. When it comes time to do an actual procedure, some people are like, I don't care, I don't have a problem with needles. Other people are like, I'm not having anything done because it involves a needle. So we prescribe Valium for people who are nervous. We have a nitrous oxide, like a laughing gas machine in our office for people who want to use that. For some of our bigger procedures, like where it's going to take a little bit longer, we have these tablets that are called MKO melts, which are, they were originally designed for people having cataract surgery. So mostly older patients. It goes under the tongue. It's got midazolam, ketamine, and ondansetron. So it basically makes you very, very goofy and loopy, and you won't care for about 45 minutes to an hour what's going on. And then so even the bigger procedures, we give IV medications. I'm an anesthesiologist, so we give low levels of sedation for patients who need it. And so there's really no reason to be anxious about anything that we would do, because we're going to make it as comfortable as possible as we're doing it. And all you need to do is just express those concerns, express your natural fear of needles if you have that. That really shouldn't be a barrier for anybody.
I love that. Great options. Any final thoughts for anyone watching this that you'd like to share about yourself, your practice, anything that would be helpful for them?
Well, my partner and I both have more enthusiasm for what we're doing now than when we first came out into practice. The way that most people come to find us is either word of mouth from their physician or from a friend or family member who's come to see us. We're slowly but surely building our library of videos about the conditions that we treat. along with some testimonials from patients, and that's on the Elite Spine Joint site on YouTube. So that's a good place for people to look at what are we doing. So it's, I think it's just Elite Spine Joint. That's our regenerative medicine. And so there's a lot of videos that we've tried to help to educate. And that's why I do it. I'm just trying to demystify things for people. And so I would encourage patients to go onto that website or onto elitespinejoint.com or portcitypain.com. And both of those websites have a lot of educational material and links to some of the videos on there as well. So if you're even thinking that there's something that we might be able to help with, I would encourage patients to go to one of those three places, the YouTube or the two websites, for further information. And I'd love to be able to help sort things out and make people feel better. So come and see me.
Yeah, awesome. And on those websites, they can reach out to your office, schedule appointments, all of that good stuff.
Absolutely.
Awesome. Well, thank you for your time today. I know everyone's going to love learning more and just, like I said, demystifying things around pain management, not the narcotics, really getting to the root cause of what is going on and then the myriad of options they have to get that treated and back to a healthy life.